hear from you, Dr. Vinay. We can't let the woman win all the time.
Thank
You
you. Thank
can't
you
say that,
for
Chitra.
Huh?
You can't say that.
right. Thanks for having me here. Dr. Kavita, a wonderful presentation, I have to say, and practically you have covered everything for me. I don't have to say anything at all. The answer, there is. I'm not sure if there is a debate in this topic at all. I'm going to compliment whatever he said. Okay, so yes, different types of allergies, but then what is more important, or what we are talking about, is the chronic severe allergies, which are VKC and AKC. And the reason till now was supposed to be, or thought to be, IG mast cell hypersensitivity in most of the cases, but then a lot of new information which says it is actually the type 4 sensitivity, hypersensitivity, that is the lymphocyte mediated reason as the cause. VKC type T helper cell 2, while in VKC both helper cells 1 and 2 are involved, and then a lot of non-specific mechanisms. So a lot of other things like genetic factors, hormonal factors, environmental, other inflammatory factors play a role here. And then, wonderful article from LVP, which shows the prevalence to be 10%, incidence 4, and peaks during this period, February to till the start of monsoon, and then it wanes off. Risk factors: males, childhood, high socioeconomic class, history of systemic allergy, and so on. Palpable form is still the commonest form which we have, but the limbal form is the worst, as all of us know. Different clinical presentation, as all of you know. But what is more important is the complications which can arise from these conditions, okay, or this uncontrolled or severe form of allergy. Beautifully again covered by Dr. Kavita: shield ulcer, microbial keratitis, keratoconus, stem cell deficiency, ptosis, dry eyes. Now, what is important here is, actually, as she mentioned, none of the treatment of these complications require immunosuppressives. Okay, the immunosuppressives or steroid sparing or even steroids. The idea of using these medications is to control the disease process and prevent any of these complications from developing. And what is traditionally used is steroids, with all the problems like cataract, glaucoma, and so on. So the steroid sparing agents, and this is how most of the topicals act. Now we know there is a majority of these group doesn't need any systemic treatment. Okay, it is topical treatment, as like she mentioned. Most of them, you can control with the topical, either short course pulse steroids or uh, steroid sparing agents like cyclosporin, tacrolimus, and so on. But then there is a small group of patients where none of these work. Okay, the only agent that actually can bring about control in these cases is steroids, topical and at times systemic steroids, which has to be continued for long, with all the resultant problems. So that is where the role of the systemic non-steroidal agents comes in. Majorly immunomodulatory agents, and the agents that have been used is cyclosporin and tacrolimus. Unfortunately, the literature available is very limited for this. There is quite good evidence for the use of systemic agents in atopic dermatitis, and some evidence for these agents in atopic keratoconjunctivitis. But in vernal, very few. Actually, I could find only one case report from Dr. Gokhle's, which has used cyclosporin for severe vernal conjunctivitis. So uh, is it really necessary? Well, if you want to go into the literature and search, you're not going to have any evidence. But then my experience and experience of few of others here, I'm sure they would have come across cases where none of the routine treatment options works, or the treatment option of continued steroid usage results in irreversible damage to the eye or vision. So when do you give systemic immunosuppressives or immunomodulatory agents? There is still no definite guidelines. The best answer, or the best possible thing which we can have now, is the classification from Dr. Gokhale, as Dr. Kavita has mentioned. And in the severe form, yes, that is one thing or probably this is a starting point where we can work to further, increase our knowledge and improve the management option in these cases. Now, what are the other options available? Is it only the immunomodulatory agents and steroid-sparing agents? Probably no. One other thing which can be considered is antigen-specific immunotherapy. Though it is not very popular, it may be useful in a very small group of patients. So probably that is one area which needs to be looked into. And then finally, there are a few reports of biological agents like anti-Ig antibody, which has been used in severe vernal keratoconjunctivitis. This is one idea which we have to really look into. So yes, as Dr. Kavita mentioned, in majority of the cases, no, we don't need any systemic treatment to control this. But then there is a definite small group. What percentage I cannot still say. It's a very small group which needs very specific systemic immunomodulatory agents to control the disease process and to prevent any long-term permanent complications from happening. Thank you.
Thank you very much, Dr. Vinay. You threw more light on this. Before Dr. San takes on, I wanted a question to Dr. Virendra Sangwan. Would you ever consider using both cyclosporin and tacrolimus, and which would be those cases?
You mean the oral or
topical?
No, both I won't use. I primarily use tacrolimus now because the topical cyclosporin preparations are not very appropriate. So I prefer to use the tacrolimus ointment, and that too at night.
Chitra, can I add?
Yes, Dr. Musa.
Chitra, I do use both the Oralab, no financial interest, but I use the Oralab Orosporin, which is 2% cyclosporin in the morning, and the Oralab tacrolimus, which is tacrolimus at night. And several of the patients have done 3 months and 6 months of such therapy. The Orosporin 2% is difficult to tolerate, so I ask them 5 minutes later to put a drop of tear drops, some lubricant drops. And only those who can tolerate the Orosporin, these are little older children, I do put them on this combination. It works better than just the tacrolimus or the tacrolimus at night. So I have a fair experience of over at least 5 to 7 years now using both in the same patient simultaneously.
Thank you, Dr. Muscati. Dr. Sayan, you could take over.
So thank you, Kavita and Vinay, for the excellent talks. I think two words that I think are important in this discussion or debate, the operative terms, I think, would be chronic and recalcitrant. I think Vinay would agree with Kavita that in those cases that, particularly children who have allergy maybe once a year, it's not that severe, it's mild. And like, Vinay mentioned in our paper also, we showed that 98, 99% of all of these cases of allergy are mild, self-limiting, etc. But we are talking of that 1% that has a chronic course, that has a recalcitrant course. They are even on topical medication are recurring. So Kavita, would you agree with Vinay that in those cases where you have thrown everything at the patient with regards to topical medication and they are still recurring on that or progressing on that, that you would try something systemic?
Yeah, I think I definitely agree. In fact, I did mention that in my closing slide that in those cases where it's recalcitrant, but I up till now I haven't found such a patient in BKC. But yes, in atopic keratoconjunctivitis, I have found such patients where, with the help of the physicians, I have put them onto systemic immunosuppressants. But maybe the cohort of patients that I'm seeing in BKC, I have not honestly used any systemic immunosuppressants by far. And I'm not saying only because I'm debating it on this side, I'm just giving my genuine experience this far.
No, I agree with you. I think Dr. Sangwan also used to make this point that depending on where, I mean, geographically also, and in terms of, what kind of patients you see, depending on where you practice, I think the spectrum of allergic eye disease that we see is very different. So sometimes when we use these words like allergic keratoconjunctivitis or VKC, etc., what we are thinking of in our minds is very different from what the other person is thinking of. So it is quite possible that what Vinay is seeing or the cases that are being referred to Vinay are usually those which are more chronic, more recalcitrant, etc. Whereas you're seeing the other end of the spectrum, and I have seen this quite often.
Yeah. Sayan, I
Does
had a
it
question.
mean that
I had.
Kavita,
Sorry. Yes, sir. Yes,
the
sir.
point sign what just it made, it also depends on what your referral practice. Say, for example, the cases I end up seeing are usually the ones you are talking about, recalcitrant and others, because I may not be seeing very early stage cases. So this is a very important point for all of us to consider when we talk about not only for VKC, any disease.
Correct.
so would you start them on oral steroids first, taper, and then start cyclosporin? How would you do the regimen?
I think what is generally done is that you start topical, and then if it doesn't
No,
respond,
systemic.
then you give systemic, and systemic sometimes has to be given in the recalcitrant cases, like Dr. Sangwan has always been advocating, even in children, because it kind of just breaks that cycle, that vicious cycle of allergy. And once that thing is broken, then it becomes easier to handle it. And like Dr. Sangwan also said, for cases like for us, they will all come, end stage allergies, because they would have had multiple treatments and multiple places they would have visited. So they'll come at the last stage to us. So we also tend to see a lot of recalcitrant cases.
No, I think so. I think most of us are on the same page, and I would say the consensus would be, and I think Vinay would also agree, that most cases present initial presentation, mild representation. You try to control it as much as possible with topical medications. Maybe for the acute exacerbations, use steroids. Otherwise, keep them on softer steroids or cyclosporin tacrolimus, like Dr. Muscati said, Dr. Sangwan said, and both our speakers also mentioned this. And in those cases where there's chronic allergy, or even where you have like perennial allergy that's there throughout the year, and patients are not really responding to topical medication, that's where the systemic therapy comes in. I think most of us would agree with that approach. Vinay?
Absolutely, absolutely. That was what I was trying to make. It's not very common to have these kind of cases present to you in your routine practice. It's most of them, I would say more than 90% of the cases you can manage with just topicals. Okay.
I had a question for, like, say, Dr. Namrata, Dr. Sangwan, and Sayan, for you also. I know if any of you have experience with the biologicals. I read up about that, and it said that especially the dupilumab, it causes entropion. So I don't know, I've really not. So does any of you have experience with these monoclonal antibodies?
I mean,
Not
most
for-
allergy
not
I
for
see is in children, so I've never really had the opportunity to try.
Can't use in children, that is there.
not with the for VKC, but for my JIA associated uveitis, I have quite a number of kids who are on biologics, who are co-managed by a pediatric rheumatologist.
Kavita, one of the, just to add, the drug that you mentioned is a specific, I think, interleukin 4 or one of those inhibitors. But red eye and conjunctivitis is a well-known side effect of this medication. It is basically used for severe allergies in the ENT, and for skin, they say it's like great, but for surprisingly for the eye, it causes worsening of the red eye and conjunctivitis. So probably we don't know all the pathways of allergy. It's a very specific drug for allergy, but doesn't work for eye VKC. For the eye, it has a reverse side effect.